Chairman, for those kind words. Thank you, Dr. Neeta and Sanjay. I'm the other Sanjay, so if you know Sanjay from before me, I'm the Sanjay from Bangalore. Trying, what we do today is go on a practical view of managing bladder dysfunction. This topic was given to me. I did a lot of reading to try and say what we have in literature, what we do practically, and how to approach a person who presents to us with bladder dysfunction. When more than 50% of men and women with diabetes suffer from some form of bladder dysfunction, and most of them are lower urinary tract symptoms like frequency, urgency, nocturia, and incontinence. And most clinical studies find that it's bladder hypersensitivity, which is more common, more than 61% of patients or bladder instability, which we can call. It is followed by diminished bladder contractibility or sensation at least, and the last thing which you can find is an acontractile bladder. And when you combine all this, and Dr. Lobo was talking about cystopathy, which is the last part of this bladder dysfunction. So what we are to prevent cystopathy and see if we can identify these problems earlier and see how we can approach them. In men, an association of obstruction in the form of benign prostatic hypertrophy can aggravate these symptoms. This is a brief introduction, so I thought I'd pick this up. I read the page that I've given up on mind over matter and concentrating my mind over bladder. That's what I'm going to do the next 15 minutes. Hope you can bear with me. So, as we age, there's more and more bladder dysfunction. Just to give you a feel as how complicated this bladder is. I always had a difficulty in the beginning of my medical school. I hope everybody did have to understand the physiology of bladder physiology and trying to look at what different lesions, what different things cause different types of symptoms. But when you look back at it clinically, they are all overlapped. So the idea what I want to try and tell you is though the anatomy and physiology which you look at, the various signals, the internal sphincter, the external sphincter, the adenemic and the PNS system, all of them are very integral in trying to understand bladder physiology and function. Meaning to say, if you have a problem, you always have to think whenever there is a bladder dysfunction, multifactorial, identifying or taking history in terms of other aspects, which I will go through over the next 15 minutes. So understanding bladder physiology becomes a very integral part when you want to treat bladder dysfunction. And one of the most common part bladder dysfunction is urinary incontinence. Now this is one of the most common, and there are very different parts of urinary incontinence. I will go through some of them and then later talk about due muscle hyperactivity and then the overlap of all this called as overactive bladder syndrome and see how we can approach all of them over a period of time in the patient with urinary incontinence. Urinary incontinence in the general community, it is present in 15 to 30% of community dwelling in persons over 65 years and older. It's more so in females, but as the age increases, it's equal. Now, what are the most common causes of urinary incontinence? Urinate frequently, usually 8 or more times in 24 hours. Sudden urge to urinate that's difficult to control. Involuntary loss of urine. Is awakened at night 2 or more times at night to urinate. So nocturia. And it significantly impairs quality of life. I'm sure majority of elderly patients walking into your clinic, most of them would have experienced or talk about these symptoms over a period of time when you treat them for long duration. Now, what are the changes you find in the genitourinary tract in an individual as he ages? And if so, what are the things which happen? The most common thing that you find is intrusive overactivity. It is 20% of an healthy continent. BPH is another problem. There's post-void residue, increased post-void residue, which also forms an important point in your history and examination to decide on the type of therapy. Nocturia, increased urinary output later in the day. In women, atopic vaginitis and urethritis. And 1/3 have multiple conditions. That's why I said whenever you have a patient with urinary incontinence, diabetes is one, but then other things which you need to take into consideration: obesity, heart failure, constipation, TIS, COPD, chronic cough, impaired mobility. All these contribute or are multiple or risk factors for developing urinary tract infection, urinary incontinence. Sorry. What are the consequences of urinary incontinence? You have cellulitis, pressure ulcers, UTI, which Dr. Lobo spoke in extensively last 20 minutes, falls with fractures, the sleep deprived, social withdrawal, depression, which is a major factor, embarrassment, interference with activities, increased caregiver burden, and contributes to more hospital admissions. What are the type of incontinence which you see? The incontinence can be transient or acute, or established UI or chronic, which can be urgent incontinence, stress, mixed, overflow. They are also, I will try and see if I can make it clear the difference between urgent stress incontinence, other things are all overlap, and transient incontinence, which is very important because it's very acute and it can be reversible. Urgent incontinence is the one which is more common in diabetic patients. Transient incontinence is usually lower urinary tract pathology, usually has a reversible respiratory factor. Half of our hospital patients with incontinent are aged patients. They have multiple disorders, neurological, psychiatric, and other, and impacted. Stool impaction is one of the commonest thing, and reduced mobility is another factor. So these are some of the common causes for transient incontinence which you have to remember. Remember diapers, delirium infection, tropic vulvovaginitis, psychosocial, pharmacological agents, endocrine excessive, endocrine abnormalities, restrictive mobility, and stool impaction. And then look at the drugs. The majority of the drugs which cause transient urinary incontinence, or many patients are taking, if you do not take a good adequate drug history, but miss patients on opioid, calcium channel blockers, anti-Parkinson drugs, anticholinergic, and prostaglandin inhibitors. They all cause depressed diffuser activity and produce urinary retention and overflow incontinence. So if you can identify these and how each of the other class of drugs like sedatives decrease awareness and decrease diffuser activity, loop dynamics, know the increased diuresis, alcohol causes polyuria, decrease awareness of awareness and causes increased urge failure and functional UI. Caffeine, increased intake of caffeine also is responsible for some of this, and cholinergic, which like increase diffuser activity and increase the urge to pass urine. So the other pharmacological agents like alpha agonists and alpha antagonists both also can be responsible for different type of urinary incontinence. Now, how do you evaluate and approach a patient with urinary incontinence? Suppose this is reversible urinary incontinence, and I've enumerated many causes of reversible urinary incontinence, which are acute, drugs, different neurological conditions, psychotropic, alcohol, caffeine, and other things. Apart from that, if you find difficulty, then the conditions require, some conditions require urological and gynecological consultations, further urodynamic studies, and then a function-focused approach on the problem which is precipitating this reversible urinary incontinence. Most common investigation, I won't go into detail, urine analysis, culture sensitivity, renal function test. Post-boil residue forms an important estimation which will help us determine sometimes type of intervention could be needed, a clinical urinary stress test, and voiding record. Whenever you do an ultrasound examination, ask for post-boil residue. A residue of 50 to 100 ml is normal. Anything between 100 and 400, you have to monitor until consistently it is less than 200 cc. More than 400 cc, please insert drainage or use of Foley's catheter to drain this urine. So this is a very important fact, and it is an important estimation for you to treat this patient subsequent. Now, what is the commonest thing you find in patients in the outpatient clinic come to you with some sort of incontinence? What is the most important test that you want to do? It's called the clinical stress test. It's very simple. You ask the patients who have that the bladder should be full. Ask the patient to strain, probably use Vulsa or whenever. If no leakage, have her perform a sit-up and cough. Look for leakage. If no leakage in supine position, repeat test in standing position. Patient should relax perineum and cough once. If immediate leakage occurs, this is urinary incontinence. If the leakage is delayed over several seconds, this means there is detrusor overactivity. So it is one of the important function, one of the important clinical tests between you and bedside to know urinary incontinence. So established urinary incontinence can be of many types, which I told you. Urgent incontinence, which is the most common in diabetic. Stress incontinence, mixed type, overflow and functional incontinence. Urgent incontinence is the most common. Here, detrusor overactivity with uninhibited bladder contractions occur. It's unpredictable, abrupt urgency, frequency, variable volumes lost, and the post-coitus urine. The volume of urine left in bladder after spontaneous voiding is normal. That is in between 50 to 100. It's not more than 100 in urgent incontinence. Management is bladder retraining, scheduled toiletry, pelvic muscle exercise, and pharmacological interventions. Please see this. Majority of the interventions here are more educational and exercise related, and last comes pharmacological related. You need to tell the patient and educate the patient repeatedly that exercise, bladder retraining, and ask him to go to the toilet at certain intervals of time, so he avoids having urge incontinence. He or she avoids having urge incontinence. Stress incontinence, the second most common in aging females. Here there is impaired urethral closure due to insufficient pelvic support. Please remember, here there is pelvic muscles which are at play, and the sphincter opens during bladder filling. So the leakage, whenever there is abdominal pressure, there is leakage. So management, again pelvic muscle exercises, biofeedback, electrical stimulation, alpha-adrenergic agonistic work, pessary or surgical interventions in later stages. Mixed incontinence, majority of the time you will have both stress and urgent incontinence in these patients. I think at this point of time you have to try non-pharmacological methods and then refer to a urologist for further management. And other thing is overflow urinary incontinence. Here there is detrusor underactivity. Please remember, you have urgent incontinence, the detrusor is overactive, or there is an outlet obstruction, continuous small volume leakage, dribbling, weak stream, hesitancy, and nocturia are the symptoms. And there is outlet obstruction, second most common cause of urinary incontinence in males. So urinary detrusor underactivity, the urinary retention and uroflow incontinence, 12% in females and 29% in men. Management, treat obstruction, alpha antagonists, detrusor underactivity, need to review medications, see if he's taking any of the medications which I told you earlier, double voiding and intermittent self-catheterization are some of the ways which you treat patients with overflow incontinence. Functional incontinence, in all this you can't come to a conclusion is whether it's urge, stress, mixed or so. You think of it's disease like it's a diagnosis of exclusion. Now what is this? When all of this overlap, you can call it an overactive bladder, meaning there's an stress incontinence, urge incontinence, and a mix of both of them. So this is what is simple. Urge incontinence, urine loss accompanied by urgency resulting from abdominal bladder contractions. Stress urinary incontinence is urine loss resulting from sudden increase in intra-abdominal pressure. So another thing before we finish is detrusor hyperactivity and pad contractility. This is more common in men, and men with diabetes suffer more with this problem. The clinical picture is a story of urge incontinence with elevated or borderline post-voidal residue. That means the post-voidal residue is between 100 to 400. It is not in the normal range. This is where you can treat, if you think of this occlusal muscle overactivity, treat most of the time it is constipation, as Dr. Lobo was emphasizing the fact repeatedly. Constipation will be one of the important factors which is causing residual urine to increase, and that in turn is increasing urinary tract infection and symptoms for a period of time. So behavioral intervention before pharmacological intervention, avoid caffeine, alcohol, minimize evening intake, pack and surgery is not option. And most of these patients should be motivated to do pelvic muscle exercises, and there is a motivated patient who loses weight and does pelvic muscle exercises as a decrease of from 56 to 95% decrease in urinary incontinence episode over a period of time. Bladder retraining, urge control exercises, scheduled toileting, and prompted toileting. Time and then prompt or somebody reminds that they should go to the toilet. And these are all you need to train this patient over a period of time to get this, educate this patient basically on scheduled toileting, repeatedly going to the toilet, even if there is no urge to go to the toilet too. So they don't have this embarrassing situation of urge or stress incontinence. Some drugs are used. These are some of the anticholinergic drugs. Oxybutynin, chlorhydrin, trospium, dalphenacin, which are muscarinic inhibitors, dalphenacin and their group of drugs, muscarinic inhibitors, which can be started at 7.5 milligrams twice a day for the overactive bladder, both for stress as well as urge incontinence, and they are the last third line after all these behavioral modifications fail in patients with incontinence. Obstruction, you have to find and always look for obstruction. Any patient with bladder symptoms, alpha antagonists can be useful, and if there is a differential attack, review medications, double boiling and intermittent self-catheterization are some of the important things which you need to remember. Please remember, if you have a post-void residue of more than 400, you need to drain, you need to look for obstruction. This needs further studies like cystometry, cystoscopy, urinary studies, and probably expert help. Now the various surgical options, I looked at them and I just thought botulinum is being used everywhere. So this is also used for the bladder. So we use botulinum for various things, and especially in an overactive bladder, we use botulinum injections at various points. So it can elevate symptoms. Sacral neuromodulation, that's not my PhD. I found it very good. I don't know, I have no idea, not seen the sacral neuromodulation to comment on it. So bladder reconstructive surgery, these are extreme cases, augmented cystopathy and urinary diversions are some of the things that the urologists do. But please remember, bottom line in every diabetic, put glycemic control, weight, and I looked at studies which looked at urological complications in any of the studies. A couple of studies, what the BPP program looked at is if there is weight loss, there is significant improvement in urinary incontinence syndrome of symptoms to the tune of 26%. The loop head study and the EDIC trial both are trying to look at urinary incontinence, and they have not come up with data. Probably in the near future we can look at this data. Long-term elderly patients who are on follow-up for more than 15-20 years, trying to see and evaluate urinary incontinence syndrome. We hope we get this data fast. In summary, urological problems in diabetic patients and in normal population in elderly patients are a significant number of patients present with these problems. Probably understanding where and looking for them and trying to evaluate and also look for reversible causes, drugs in particular, associated neurological conditions which play a major role in assessing bladder dysfunction, and check post-voidal urine, and if it is more than 100, if you can't read, please refer to a urologist or a nephrologist, they can do better. early referral if underacted urinary tract pathology is suspected. Thank you very much for listening.